very much for inviting me for this HASICON. And for next 15 minutes, I am going to speak on the topic of changing paradigms in the management of incisional hernia repair. Sigmund Freud, all of us know, Austrian psychoanalyst, he had beautifully written, do as much as possible for the patient, do as little as possible to the patient. What I mean to say is, our endeavor should be that we should not cause much harm to the patient, and we should try to go in a minimal invasive manner so that ultimately the patient is the beneficiary. And in this, I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. Now, all of us know the paradigm is shifting. Why? Because there are patients who are having incisional hernias of this kind. Initially, all of us knew that, for example, if it is a 3 centimeter defect, 4 centimeter defect, and it is an incisional hernia, then definitely all of us were going in for IPOM plus. But in last 2 decades, all of us have seen that open surgery has come down, or it is coming down, and laparoscopic surgery has reached the plateau, and robotic surgery is going up. And especially for my younger colleagues, I would definitely urge them that if they can lay hands on the robotic training and then they do the robotic surgery, definitely they are going to do the least damage to the patients. And what are the options available? Options are either we can go in for open and we place in a onlay mesh, or we can place the mesh inlay, or retromuscular, or intraperitoneal. But again and again, realization is that the chances of recurrence are definitely least when we are placing the mesh in the retromuscular space. And there have been publications also, not that we are against IPOM plus or IPOM, but there have been publications and experiences that the complications of mesh placement into the peritoneal cavity definitely had lot of damages also. Means if the infection is there, then also adhesions are there, erosions are there. So one had to progress, but again the writer is, yes, we are not saying that IPOM plus is dead, but IPOM plus is there and it will remain. But there are bracket of patients in which we know that we have to be very, very careful, especially when this defect size is becoming larger and larger. And again, initially, all of us have been taught, Dr. Bhardwaj is there, Dr. Singla is there, all of us have been taught that an overlap of 3 to 5 centimeters had to be there so that the recurrences are reduced to the minimum. But this had been proven wrong in the last changing paradigm, and now it is a mesh defect ratio. Area of the mesh, area of the defect, and if you calculate the ratio, if it is less than 8, then the chances of recurrence are of the order of 70%. And if the mesh defect ratio is more than 16, the chances of recurrence are duck. So thinking is definitely one should carry on unlearning, learning and relearning. And again, I am re-emphasizing because of the intraperitoneal proline mesh, because of the different meshes, the complications have been reported, and the complications are there. If some surgeon says that I have not seen the complications, I think he is fooling himself rather than anybody else. So seroma, hematoma, recurrent pains, surgical site infections, bowel adhesions, bowel erosions have been reported. So again and again, our thinking is, yes, one has to decide that the mesh is not coming in direct contact with the intestines. Be it a dual mesh also, so we should try not to place it. And if, for example, only mesh was placed in open surgery also, the repair was under tension and the skin flaps were large and there was more chances of seroma formation and it was having high recurrence also. And again, I am proving, especially I am telling my senior colleagues that those who are still doing the open surgery and still believing in the onlay mesh, the chances of higher complications are definitely there. And once we are placing the mesh in a recto-rectus canal or recto-rectus method, then the chances of seroma formation is also less, this infection is also less, and again the chances of recurrence also becomes less. And either we place the mesh in a retromuscular space by open method, by laparoscopy or by robotic, definitely the chances of complications are less. In the last, I would say again a decade, 2012, Jorge Dias had beautifully written an article on enhanced totally extraperitoneal hernia repair. And in this, he described it in 2012 about the inguinal hernia. But it progressed very fast, and then they started doing the large inguinoscrotal hernia also with eTEP. What is eTEP? E is enhanced or extended. So if you see, you must have seen the painter painting it. So once the painter wants to see whether he has done a good job or not, he withdraws himself, sees from a distance, and he thinks that he has done a good job. So what I mean to say, in enhanced or extended TEP, the trocar positions are higher into the maybe left subcostal region or right subcostal region. The scope is there and we are seeing from a distance, and definitely that helps. But again, when Jorge Dias had described about inguinal hernias, then there was again a paradigm shift, and it was projected for ventral hernia repairs also. And Igor Belinsky and different other surgeons also saw lot of promise in tackling the ventral hernia, incisional hernia repairs by eTEP method. And this is a small video clipping. I am not going into the detail, but again and again I would emphasize, eyes don't lie. Eyes don't lie. We always make the port under vision, opti view, and one can see we have gone into a retromuscular space, and posterior rectus sheath is beautifully seen. With the help of the trocar blade, we are just taking care of the adhesions, and we are gliding ourselves into the retrorectus space without putting in our finger or saline or PDB balloon or anything of that sort, and the clarity is there. We prevent any injury to any smallest bleeder also. And now with the advent of eTEP, we are doing only with 3 ports the complete incisional hernia repair. One is in the subcostal region and 2 are on the left side just close to the linea seminalis. And once we are able to place in the trocars under vision, again and again I am emphasizing, eyes don't lie. So one should always make all the port entries under vision, and with the help of harmonic or with the help of hook, one can carry on dissecting onto the posterior rectus sheath. We are going close to the arcuate line, and the arcuate zone is seen, and then we carry on dissecting the loose areolar tissue up. And once we have cleared the retrorectus canal on the left side, now is the endeavor, our endeavor would be that we have to go on to the right side. And for going for the right side, we have to make a crossover. And how do you make the crossover? This is called a superior crossover. With the help of hook, we are giving an incision onto the posterior rectus sheath on the medial border of rectus abdominis, just close to 5 millimeter to 1 centimeter, close to the linea alba, and one can appreciate the fatty triangle. Means one can see the fibrofatty tissue of the falciform ligament. We take it down and then we cross over to the left side, and with the help of hook or bipolar or harmonic or any instrument, we are able to make the right rectus canal also. So once we have given an incision onto the posterior rectus sheath, then we are able to unify both the rectus spaces, and then we go close to the defect, and after once we have cleared it, then we will be in a position to cover it with a large size mesh. Again and again, I am reminding all of you about the mesh defect ratio. If the defect ratio is less, definitely the chances of recurrence has to be seen. So our thinking is that please do not place in a small size mesh, place in a large size mesh, from one linea semilaris to another linea semilaris, from the epigastric region to the pubic ramus, so that and we are closing the linea alba also. We are making sure that both the recti are closed to each other, so that ultimately it becomes a functional repair rather than only an anatomical repair. So I will not go further into the details. These are available on the YouTube. Definitely you are more than welcome to see them. But again and again, our thoughts are, yes, IPOM is going to stay. It is not dead, but it is coming down. So that is a changing paradigm. And in this robust hernia project also, they had studied 451 patients, and IPOM was being done in 52% cases in 2015, but now it is dropped to 14% and similarly we started our robotic program, and never ever say that it will be the future. Robotic surgery is not the future, it is the present. So we started our program of robotic surgery in March 2012, and we did it for super morbid obese patients. And again, so many randomized controlled trials have also been proven. And again, I would say robotic surgery has an edge over the laparoscopic surgeries for those complex abdominal wall hernias. So one should be very well trained, and one should carry on unlearning, learning, and relearning. And in the end, I would just take one statement of Ristopa. Stopa, all of us know Ristopa is the technique. So for ethical, professional, and economic reasons, these are the days of hernia surgery with dark recurrence. Thank you very much. Thanks a lot for your kind attention. Any questions? I am more than happy to answer.
Thank you very much, sir, for such an informative and engaging session. Now the house is open for discussion. Any questions from the audience?
I want to know, failed repair by mesh. What will you do? Mesh is there, patient has got recurrence, and these are very tough cases. So what is the treatment?
Excellent question. If there is a recurrence after, for example, IPOM plus, then, or if there is a recurrence after open surgery, then, or if the previously open surgery has not been done on the laparoscopic. So thinking is, one should know the anatomy well, one should know the plans well. Planes also, God has created the planes only for us, the surgeons. So we should know the planes, and we should definitely not attack the enemy from the same route. If we attack the enemy from a different route, for example, if the previous laparoscopic surgery has failed, then one should go in for, if you are well equipped, you can go in for open surgery, you can go in for robotic surgery, you can go in for laparoscopic other method. And similarly, for example, in inguinal hernias also, if the recurrences are there after TEP, one can still go in with TAPP. if the already open surgery has been done. So what I mean to say is change the track, change the mindset, and then attack the enemy. The chances of recurrence will be reduced to zero. Yes, sir, Dr. Bhatia.
Always nice lecture by Dr.Parveen Bhatia.
Thank you, sir. Thank you.
One statement you made in start. Do maximum for the patient, but do minimum on the patient. But putting such a big mesh, छोड़ा ही क्या?
Good one.
So the virginity of the abdominal wall goes away. This many times comes to my mind,
Sure.
and today I would ask you,
Sure.
because you are the finest hernia surgeon.
Thank you, sir. Thanks for the compliment. But I would always say that my was not my statement, but it is still I believe in that if you have to place in a large size mesh for a recurrent hernia, and if you give an incision from epigastric, from xiphoid to the pubic symphysis, and then you open the retromuscular space, and then you place in a 30 by 20 size mesh, obviously I am harming the patient more, because the chances of infection are more, the chances of complication are definitely higher. And same thing which I also mentioned, and Sigmund Freud had also said, do the minimum on the patient, means make just 3 ports, full stop, 10 mm, 5 mm, 5 mm, and place in a larger. If we can, ultimate aim is, it has to be a duct recurrence. So if we are able to place in such a large mesh, I am not saying that place such a large mesh for a small primary hernias, no. But for recurrent hernias, if such kind of situations are there, definitely one should try one's best to go in, invade the field by minimal incisions, but doing the maximum for the patient, rather than patient has recurrence again and again. He should not become a survivor or sufferer of hernia surgery. He should definitely have, we should aim for hernia recurrence is done. Yes.
If that mesh gets infected and it is very difficult to remove the mesh, what is the alternative?
Call for help. If it is what I mean to say, yes, good question. The senior surgeons know that when the open mesh hernia repair had already been done, the mesh infection was there, definitely it can become challenging, especially if it is, for example, polypropylene mesh, it had been placed. One has to be very, very careful if it is placed just close to the blood vessels, if it is close to the intestines. So one has to be very careful. One should go with ample patience and ample time, and then go in for surgery rather than do it in hurry. One. Second thing is, in laparoscopy, we have, all of us have seen also, in laparoscopy also we have been able to explant the mesh. Again and again I am re-emphasizing that please do not hesitate to explant the mesh. Many times I have seen, and we see such kind of cases, that people do the partial excision of the mesh and the patient starts having discharging sinus after few days. Again the surgeon does few centimeters more, and again. So ultimately patient has to suffer a lot. So our thinking is, right from beginning, train yourself, train the patient that it is a difficult proposition, so refer to your enemies like us, and then we can take the mesh complete out and the tackers also completely out, so that the patient does not have a discharging sinus later on. Dr. Chawla, please.
Thank you, Dr. Bhatia, for an excellent presentation.
Thank you, sir.
And I am thankful to you that you accepted our invitation. So I will say one word, like dial 112, dial 507 in case of any help. Dr. Bhatia is always available online. He never refuses if you talk to him.
No,
Secondly,
but my answer to this is, if brother like you or teacher like Dr. Madan, they give us a phone call, and if I don't respond, it is wrong on my part. At least I will never ever dare to do this.
Sir, one more question, sir. One more question, sir. If you find on CT scan, if you find a irreducible bowel as the content, what do you prefer, TRM or eTEP, sir?
If you are finding it irreducible,
Bowel is the content.
yeah, absolutely. Good question. Answer is try the dictum, the tip and trick of this trade is that after the induction, try to reduce it. If you are able to reduce the hernia, nothing like it. If you are not able to reduce it, then be open for open surgery also, and be open for doing a diagnostic laparoscopy. In my position, I would definitely do the diagnostic laparoscopy, and I will assess my surgical skills that whether I will be able to reduce the irreducible bowel content or not. If I am able to do it, then definitely I may place in a mesh. But if it is irreducible and lot of traction has to be applied, no way, I would never go further. I will just go and do a hybrid repair rather than causing any iatrogenic enterotomy.
Thank you, sir.
Thank you.
I once asked Dr. Bhatia what is the secret of success. He told me early rising, regular consistency. He is always up at 4 a.m. and you can listen to his Sunday stories every week. Am I right, sir?
This was a commercial break. Thank you.